Good morning, ladies and gentlemen. It's a great pleasure to be here, seeing that the Asian Association is thriving, and every year we see more and more attendance. So that's really very warming to see. Thank you very much for the invitation, and my task this morning is to discuss the double outlet right ventricle with non-committed ventricular septal defect. I'm sorry about my voice, but I've been recovering from a recent cold in the summer. Next slide, please. I think for the surgeons, it's always nicer to keep things simple. And we have seen a similar slide, but I think if you look at the double outlet right ventricle, it's just one of these types. Subaortic location of the ventricular septal defect, subpulmonary location, related to both arteries and remote. Can I advance from here? Okay. So management of double outlet right ventricle associated with anatomically non-committed ventricular septal defect actually remains a surgical challenge, and the limits for and specific outcomes of anatomical versus single ventricle repair is still not well established. And the challenges really concerning decision making arise from those subtypes that are in the gray zone. So we have the clear-cut cases that can have a two ventricle repair, and there are some cases that clearly cannot have a two ventricle repair. And the challenge lies on those cases in between that would be considered in the gray zone. If you look at this paper, old 1996 from Great Ormond Street, is a high-risk biventricular repair always preferable to construction of a single ventricle repair? If you look at the outcomes or the conclusion from the paper, two ventricle repair, single ventricle repair, this is kind of in general, not only related to double outlet right ventricle. So two ventricle repair can be complex and technically demanding, while the single ventricle repair is less complex and less demanding. The short and mid-term morbidity and mortality is greater in the two ventricle repair than the single ventricle repair. There is also greater need for reoperation. Reoperation is less likely with a single ventricle repair, and there is also need for pacemaker in some cases with a two ventricle repair. And however, if we look at the long-term outcomes, the probability of having a better outcome with the two ventricle repair is better. However, some authors documented better survival after Fontan palliation in patients with complex form of double outlet right ventricle, including patients with straddling atrioventricular valves. This is just looking at various strategies in patients with CCTGA, just to emphasize the fact that if you look at the survival, you can see that the line for the Fontan pathway is flat compared to other strategies where there is a constant attrition. This all looks into this about for 10 years, and not beyond. But when anybody looks at such a curve, really gets impressed and feels that probably a single ventricle pathway is an easier and maybe a better way to go. And it has been mentioned that a good Fontan is better than a bad two ventricle repair. Some argue, however, there may be situations in which the short and medium risks of a complex biventricular repair may outweigh the long-term disadvantages of a single ventricle approach. Understanding the limitations of the long-term outcomes of the Fontan circulation, there has been always attempts to do two ventricles and sometimes 1.5 ventricle repairs whenever feasible. The limitation of the Fontan circulation have been really known from the very early days. This is a combined series between Alabama and Bordeaux with Fontan and Kirkland cases. And you can see that there is a constant attrition in the patient's survival with the Fontan circulation. Also, a publication from the Mayo Clinic in circulation demonstrates that there are ongoing problems with the Fontan, including sudden death, heart failure, thromboembolism, and others. And this is also from Mayo Clinic, 40-year follow-up after Fontan operation. And the conclusion, as the surgical techniques for the Fontan operation have changed over the last 40 years, survival has improved. However, development of PLE and arrhythmias and the need for reoperation during the long-term follow-up pose significant management challenges. And this is the mortality, the survival care for patients who are diagnosed with protein-losing enteropathy. You can see that the survival is really very dismal. With all these limitations, our policy in general has been to try and do biventricular repair for double outlet right ventricle, various forms, including those with non-committed VSD, as we feel that this is a better option for the long-term outcomes, and for, however, it's technically very challenging. So ideally, to be able to do that, we should have two good-sized ventricles with good function and with good two atrioventricular valves. There should be ability to route the ventricular septal defect to the aorta by what would be, for the nature of the disease, a long interventricular tunnel without leading to left ventricular outflow tract obstruction. And it's very important that that particular tunnel should not encroach on the right ventricular outflow tract. Additionally, we should have normal systemic venous and pulmonary venous returns. 3D printing, as has been alluded to earlier, and can be helpful to delineate some of the problems associated with such repair. However, I must say that, you know, if you look at the echo, the CT, the MRI, the 3D printing, there are certain patients where you cannot really tell. And the only time that you can tell whether you can do it or not is intra-operatively. And therefore, one has to go in with that mind that I would like to do a biventricular repair and see if this is feasible. And even presence of tricuspid valve problems in the, during the repair, say a papillary muscle or what have you, that may prevent the tunnel. Still, there are techniques to relocate the papillary muscles and be able to do the tunnel correctly. This is just going through some techniques to do the biventricular repair. And I think the easiest or the simplest is a tunnel where actually a pathway is constructed to lead the blood from the left ventricle through the VSD into the aorta. And sometimes this requires VSD enlargement, and one has to be careful, of course, doing this because have to pay attention to the conduction tissue as a heart block may happen. Generally, if there are no papillary muscle tricuspid valve, there are no other structures, intracardiac anatomic structures, this can be performed easily. However, if the VSD is a little bit further or you require a larger tunnel, as mentioned, you may end up encroaching upon the right ventricular outflow tract, and you might have to do something to get rid of that obstruction, either by a tunnel enlargement of the pulmonary artery transanular patch or even a conduit. And this is how you want to really end up with the tunnel of a pathway from the LV to the aorta without obstruction. However, routing the ventricular septal defect to the aorta may be limited by tricuspid valve apparatus or by the distance to the aorta. And it looks like routing the valve, the VSD to the pulmonary artery might be easier. And of course, in those cases, you need to do arterial switch as well. You have just heard an elegant talk about how to deal with coronary arteries in this situation. And actually, the interventricular tunnel repair with a long pathway can be made much easier utilizing multiple patches. And I really like this technique very much. This was described by Miguel Barbero Marcial from Brazil, where actually they utilized 3 patches to construct the tunnel from the ventricle to the aorta. And as you can see here, one patch probably with this kind of anatomy can be folded, kinked, or and maybe using the multiple patches would allow you to have a very nice tunnel without obstruction, and also with patches that are aligned nicely without having kinks or occlusion. Their conclusion that the use of the multiple patches for biventricular correction of this anomaly simplifies and renders feasible the interventricular repair in case in which the one-patch technique was deemed impossible. Most of the time, I think 2-3 patches can be utilized and can lead to a successful tunneling of the VSD to the aorta. But again, one has to be careful about the size of the right ventricle and the egress of the blood from the right ventricle to the pulmonary artery. This is another technique that was described actually using a intracardiac conduit between the ventricular septal defect and the aorta, and it was mentioned here that it seems a simpler technique to do the routing. Personally, I have not utilized this particular technique. The last option, which appears to be very complex and maybe in very special cases, is the double root translocation for outlet right ventricle with non-committed ventricular septal defect, or double outlet right ventricle with subpulmonary ventricular septal defect associated with pulmonary stenosis. And this is described from China, where actually you deal with the two outflow tracts, they all disconnected and reconnected with double root rotation, where the pulmonary artery is rotated towards the RV and the aorta is rotated towards the left ventricle, and the VSD is patched. And this is the final outcome. However, despite all this, there are conditions that may preclude good biventricular repair, and most importantly are significant ventricular hypoplasia, particularly of the right ventricle, severe atrioventricular valve straddling or overriding that you cannot go around by either translocating papillary muscles or otherwise. There are some multiple Swiss cheese-like multiple ventricular septal defects that also may make septation very difficult. And of course, the presence of other reasons to make the complexity of the intracardiac anatomy preclude constructing a good tunnel. And under those circumstances, probably a single ventricle pathway is the reasonable way to go. But one has to remember, in some, because we'd like to operate on those patients being young in the infancy, in some situations, single ventricle route can be an initial strategy where actually you can just do the, if there is an arch problem, or do the bidirectional glen and wait, and one can still consider biventricular repair later as the child grows and things may become technically easier with an older or larger size child. I must emphasize, and actually there are many, probably particularly of our young surgeons, that would look at the Fontan operation as being a bad operation. But I think one has to really keep in mind that that the Fontan operation provided excellent palliation for patients who otherwise would have not survived. And however, in a way, it remains a palliative procedure with unfavorable long-term complications in some patients. In some patients, it's not in every patient, and therefore, every effort we should try and consider biventricular repair in patients with difficult anatomy, on whom a single ventricle repair is considered an easier option. So the conception, we have what I would call a paradox in here. You have the Fontan operation, which is an easier operation to do. Long-term outcomes may be not as good as biventricular repair. The biventricular repair gives you a longer-term outcome. It's more difficult technically to do earlier, and one has really to balance the two together, keeping in mind that Fontan is a reasonable palliation, and biventricular repair is also a better option. So with this, I end up. Thank you.